Hi, I'm honored to participate to this Diabetic Food Awareness Week in Africa region, and I will talk about Tunisia's battle against diabetic food ulcers, screening methods, and efficacy. I will begin by these declarations in the IWGTF document. 80% of people with diabetes live in low and middle income countries, and it continues by very many diagnostic tools are not readily available and are unlikely to become so in the near future. So these are pessimist declarations, but unfortunately it's the reality. 1 in 4 patients with diabetes will develop diabetic foot ulcer in their lifetime, and 80% of diabetic foot ulcers can result in some form of lower limb amputation. If I look to the situation in Tunisia, the prevalence of diabetes is almost 10%. So if we are 12.3 million inhabitants, probably 1.2 million persons have diabetes, and probably 300,000 persons will develop diabetic foot ulcer. In slide, I want to compare our public sector to private sector of healthcare. If you compare the number of healthcare structures between 2011 and 2021, we observe that the number has increased about 30% in the private sector, but remained almost the same in the public sector. So the private sector is evolving at a greater speed than the public sector and has more means and facilities. The consequence is this: when for example, for the diabetic foot, when we put in Google Tunisia and diabetic foot, we look appear some links to private clinics managing diabetic foot and offering preventive and curative management. Unfortunately, what's the situation in the public sector? We have only 4 formal clinics of diabetic foot, 2 in the capital and 2 outside the capital, and they are all in third line structures, university hospitals. This is the governorate of Mahdia, in which our team works. It's very extensive with many rural regions. Some of them are more than 100 kilometers far from our tertiary hospital. So our hospital is a university hospital serving a population of 600,000 inhabitants. In our hospital, we perform 30 amputations in every month, and it includes, in average, 4 amputations caused by severe arteritis. We provide to our patients, diabetic patients, multidisciplinary care. And for the diabetic foot also, we manage complicated wounds referred to us by peripheral hospitals, as well as those of our patients who develop wounds. We are a multidisciplinary team. We have diabetologists, specialists in infectious diseases, surgeons, vascular surgeons, specialized in physical medicine and rehabilitation, and other medical specialties managing diabetes, such as cardiologists, nephrologists, dentists. So the prevention of diabetic foot ulcer begins by a good feet examination. It will allow us to screen patients who are at risk for ulcerations. This feet examination should be made yearly. It should assess if the foot is ulcer-free, assess the lobes, the loss of protective sensation by the monofilament Siemens-Weinstein, and assess the vascular states. This fit examination will allow us to screen a diabetic food risk, and in this field we have made a study, risk assessment for food ulcers among Tunisian subjects with diabetes, a cross-sectional outpatient study. We performed this study in 230 outpatients. We examined their food according to the IWGDF guidelines. We found that 36% had arteriopathy of the lower limbs, 23% had neuropathy, 43% had deformations of the foot, and 4% had a history of ulceration and or amputation. So in the group 0, category 0, we had 53%, in category 1, 25%, in category 2, 18%, in category 3, almost 4%. But in the group 0, we have, this is the old classification of IWGDF, before 2020, and so the group 0 includes also patients with isolated arteriopathy of lower limbs. We looked at risks as factors associated with higher or lower risk of ulceration, and in multivariate analysis we retained that retinopathy and hyperkeratosis were associated with higher grade of ulcer, and school level was associated, high school level was associated with lower grade risk. But currently, this gradation risk is not noted in daily practice, mainly in outpatients given overloaded consultations. We project to make it systematically in all patient files in order to implement aspects of IWGDF guidance in our department, and in a second time we aim to generalize its use in peripheral, primary and secondary healthcare structures of our governorate after preparing the ground, it means after making education, appropriate education. This screening of diabetic foot risk will allow us to provide targeted therapeutic education. We provide therapeutic education of diabetic foot to patients in our department and in our hospital, and we aim to primarily deepen knowledge of healthcare professionals of our department to the problem of diabetic foot, and then provide education to healthcare professionals in first and second degree structures of our governorate. We have to treat and prevent trophic disorders and pre-ulcerative lesions in our patients by encouraging routine wearing of appropriate footwear, and luckily therapeutic footwear is supported by social security funds in our country, but the problem is this service of fitting and taking measurements is available only in third line structures, and the second problem is that manufacturing of these soles or shoes can take a long time. We have to treat risk factors for ulceration and pre-ulcerative lesions in our patients. This is the podiatric care, and the podiatric care can be a problem in our country. We have lack of podiatrists in some third care structures like our hospital, and we project to recruit a podiatrist by 2025. Administration is alerted about it, and to acquire material for podiatric care, which can be more difficult. So we have to go step by step. We must target pitfalls in our management of diabetic foot, education of healthcare professionals as well as patients, risk assessment for foot ulcers, and provide podiatric care for our patients. Thank you very much.